Hello, and welcome to today's Lunch and Learn presentation, Weight Loss Surgery. Is it right for you? I'm Dr. Stephen Reinches, the President and CEO of North Kansas City Hospital. Thank you for joining us. Obesity is a complex disease with many contributing factors. Being overweight can increase the risk for developing serious and often life-threatening health issues, such as heart disease and stroke. Today's speaker is Dr. Keenan Berghoff, the Medical Director of the Total Weight Loss Center. The Total Weight Loss Center offers both surgical and non-surgical weight loss options to help people achieve both their weight loss goals and a healthier lifestyle. Dr. Berghoff is one of the Total Weight Loss Center's 2 bariatric surgeons. He's here to talk about the health risks of obesity and the health benefits of bariatric surgery. Dr. Berghoff is a board-certified general surgeon with fellowship training in advanced laparoscopic surgery and bariatric procedures. He earned his medical degree from the Indiana University School of Medicine. He completed his residency at the University of Missouri, Kansas City, and his fellowship at the Texas Endosurgical Institute. Please join me in welcoming Dr. Berghoff.
Thanks, Dr. Righteous, so much. Thanks for everybody joining us during this middle of the day lunch hour. As Dr. Righteous stated, we're going to talk about obesity, and unfortunately, it's a significant prevalence in our Western Hemisphere, the associated problems with obesity, and on a more positive side, the treatment of such and the help that we can offer patients who do suffer from this disease. So we'll go ahead and get started and answer some questions towards the end of the presentation. Thank you again. First of all, we're going to talk about what is obesity, its health risks, and the treatment options, like we just said. So, a simple definition of obesity, it's an excessive amount of weight, so everybody, based on a patient's gender and height, they should have an ideal body weight. So obesity is somebody weighing over that ideal body weight. Genetics do play a role. There are genetic abnormalities on the DNA strand that set up a patient for obesity. But it is a complex disease, like stated in the introduction, that there are a lot of factors involved. So us as healthcare providers need to not just focus on surgery, which is the majority of what we do, but treat the broad spectrum of the disease. Oddly enough, this disease has been talked about for 2,000 years, ever since the beginning of medicine, but not until 2013 did the American Medical Association finally recognize it as a disease. So it took us a while to get there. We've got a long way to go to recognize this as a serious health threat to our society, but we're moving in the right direction in terms of treatment. You may know about or hear about calculation called body mass index. It's basically an objective way to figure out a patient's weight. In other words, taller patients should weigh more than shorter persons. So if you take a calculation, like most things, you can Google it. You put in BMI, out comes, you put in your height and weight, and out comes a number. We say normal BMI is 20 to 25, overweight is 25 to 30, and then obesity levels are 30 or higher. So we'll talk about this later when we discuss surgery and candidacy for surgery. Obviously, what causes obesity? There are many different causes. There are medical disorders that patients have. There's a few listed here: diseases, hypothyroidism, polycystic ovarian syndrome, rare diseases like Cushing's syndrome. Those are diseases that lead to obesity. What we're going to be mostly talking about is kind of the disease of obesity, which is hormone-based. In other words, a patient storing calories too well in the setting of our current society, where we're a little less geared up towards activities. Socioeconomic status plays a role, no doubt. Patients don't have access to certain things that would make them healthier. They're more predisposed to have an obesity, and obviously there's some eating disorders that could lead to obesity. But the real main focus for today's talk is the disease of obesity and those that have abnormalities in their physiology that lead to too many calories stored as fat and too less calories burned. But we're going to hammer home this hormone related issue here in a little bit. So why are we talking about this? As most of you know, and as has already been stated, there's a lot of health issues that go along with obesity. And unfortunately, some of the more life-threatening life-threatening ones are most common, such as heart disease, stroke, high blood pressure, high cholesterol, leading to heart attack, stroke. And we know that patients have a BMI over 40 or a weight that gets them to that classification. They live about 4 to 8 years of less lifespan than somebody who lives with a BMI under 40. Some of that has to do with cancer. In other words, cancer incidence is higher in patients that are overweight. Uterine cancer in female, breast cancer in female, colorectal in male and female. What else? Gallbladder disease. There's pulmonary disease. You may have heard of sleep apnea, which is a common disorder associated with obesity. That's when a patient basically stops breathing at night. Luckily, their brain wakes them up and they continue breathing. But not only does it lead to daytime sleepiness, but it has a lot of health issues: irregular heartbeat, high blood pressure, heart disease. Organ dysfunction, as patients are overweight, they may store weight in their belly or their legs or their hips or their rear, but there is fat storage on the internal organs, which is even more damaging, to the point, for example, we currently are transplanting more livers for fat-related diseases, storage locations, or fat-related disease of the liver than we are, say, cirrhosis or cancer. So that's the downside of things. The upside is that these disease processes are reversible should the patient lose weight. And that's kind of what we're going to focus on mostly, is the treatment of obesity. And hopefully we'll generate some good questions for you at the end. I think everybody's tired of hearing about pandemics and epidemics and that nature, but we really do have an epidemic going on in the U.S. population, and really the Western Hemisphere. So currently in the U.S., there's about 30% of patients or people in the U.S. are in the obese category. And that number is going to jump to over half just by year 2030. So that 50% of the U.S. population would end up over the obese category. Sort of to illustrate that point, I'll go quickly through this, but this is the trend we're taking. So in the 1980s, the Center for Disease Control started collecting information. Hey, what does the U.S. population weigh? Well, we didn't have much information back then, but we did realize, the U.S. in that time frame, 10 to 15% were in the obese category. So which is this blue color, obviously. So we'll go ahead and march through this picture of the U.S. map. You get into the 21st century, boy, we have to come up with other colors because we're much higher than 15 to 20%. Greater than 20% started showing up in these states in the 21st century. You get the idea. It's not getting better. And it's also an issue common in the Midwest and Southeast, of course, Midwest where we reside. So this is an issue that isn't getting better. We need to come up with additional colors. As you can see in this map, a good majority of the U.S. population is at least 25% or higher obese. So this number is getting higher and higher with time. And you could show on this map also that the percent of patients that have obesity, high blood pressure, high cholesterol would have a linear increase with this too, or a parallel increase. So this trend is what we're trying to get to stop here. And that's pretty much mostly what we're going to be focusing on. So there are a lot of options for patients being overweight. You name it, it's been tried. Hypnosis, acupuncture, fat freezing, you name it, it's been tried. It's a multi-billion-dollar industry, weight loss. So what are options? So there's behavioral therapy, seeing a psychologist, or seeing a therapist, identifying stressors in somebody's life, trying to get them to lose weight. Diet, of course, Weight Watchers, Slim for Life. Many patients that we see, well, essentially nearly everybody that we see has tried this list, everything, and more than once. There are medications out there that are designed to help a patient lose weight. They're mostly centered around appetite suppression. They do have some effectiveness. They do have side effects long-term, may not be the best option for patients. Interestingly, though, there is a group of patients where this medicine is more effective, and that happens to be the postoperative surgery patients, bariatric surgery patients, which we'll talk about. So there are some people, for one reason or another, that may regain weight after surgery. And luckily in our center, like Dr. Wright just had mentioned, it is a total weight loss center, meaning we have all modalities of treatment. We do have a weight loss doctor that in the clinic that is not focused on surgery like I am, that can help our patients prepare for surgery beforehand, and should they run into trouble, help them after surgery in terms of how can we get them to continue with their weight loss. And medicine does play a role in that particular subset of people. I kind of list surgery as the last option. It is the most invasive option, but as we're going to talk about here in a second, it is very safe and is the treatment of choice for this disease currently. I think as we learn more from surgery, eventually we'll be able to figure out exactly what's happening in surgery and pharmacologically be able to come up with something to treat it non-surgically. But luckily, surgery is very safe, very effective, and long-term super effective. So one of the main reason I brought up body mass index earlier is this is how we figure out, who's a candidate for surgery. So when you put in your height and weight, like we discussed, if you come up with a body mass index or a BMI of greater than 35, and you have one or more of the health problems we mentioned, then based on the National Institutes of Health criteria, those patients are a candidate for surgery. In other words, if you have a BMI of 35 and you have high blood pressure, high cholesterol, diabetes, or sleep apnea, not all of them, one or more, then you're a candidate for surgery. There are patients that get to be a BMI of 40 or higher, and they haven't picked up those health problems like we just mentioned, but we consider those a candidate for surgery as well, because as you saw in that graph, with time, they'll eventually pick up those health diseases. And as I mentioned earlier, people with a BMI of 40 higher do live a shorter life. We think about 4 to 8 years. Insurance does cover these procedures because they luckily have figured out they can save money with healthcare costs by getting a patient to lose weight. In fact, a healthcare insurance company gets back everything they spent on the surgery within 25 months. In other words, they're paying less to pharmaceutical companies, less to doctors' offices, because the patient is healthier and requiring less. But the health insurance companies may or may not say, hey, we want a patient to prove that they've tried something before we allow them to have surgery, which is unfortunate because essentially everybody who's come to our office has tried anything and everything, but nonetheless, that may be the case. So the insurance company may say, hey, we're going to cover surgery, but we want you to go to your doctor once a month for 3 months or 6 consecutive months, saying this patient has obesity, they've tried to lose weight, they've been unsuccessful to lose weight before they give the final approval. In our office, that that could be an arduous task for a patient trying to navigate all this stuff we want them to do before surgery. So, if that's the case, we have employees in the office, bless their heart, that do this all day long, and will navigate that somewhat problematic process. But basically, from a science standpoint, from our standpoint, if a patient has a BMI 35 or higher and they have a health issue, then they would be somebody who it makes sense from a risk benefit to have surgery. Now, I wouldn't get too, it's a colorful slide, but I wouldn't get too bogged down about it. But the point I'm trying to make is, this is a disease, and I want patients to know, or people watching to say, this is not about patients, just being lazy and could lose weight, but they just don't want to. So there are hormone abnormalities that are definitely wrong in patients that are overweight. In fact, we don't refer to it as weight loss surgery or bariatric surgery anymore. We call it metabolic surgery because something's wrong with their metabolism. And I could, geek out and go on and on about this, but one example I like to say is there's a hunger hormone that some people may have heard of that just works wrong in patients that are overweight. So in a normal setting, when somebody doesn't have to deal with the obesity or the disease obesity, this hunger hormone goes up in between a meal, tells the brain, hey, we better consume calories so we can do normal function of the day, so our brain can work, our heart can work, our lung can work. After that patient who doesn't suffer from obesity eats, that hormone will precipitously drop. So they have that feeling of fullness, they go about something else, and then they're not hungry for a while. Somebody who's overweight, that hormone does go up in between a meal. They will eat the meal, but that hormone will stay up there, kind of hover up there, and it won't precipitously drop. So they have it's not uncommon, they have a harder time getting full and staying full longer. It's not uncommon to hear patients talk about or think about food the moment they wake up till the moment they go to bed. One thing we learn kind of by happenstance as you operate on the stomach in a patient that has obesity, well, after surgery, that hormone does go up like it's supposed to, but after they eat, it precipitously drops like it should have before surgery. In other words, if we pulled blood samples out of a patient before surgery, did the surgery, pull blood samples out of them after surgery, gave them to a scientist to look under the microscope, they would think they're two different people. So this is, again, this is a disease which I want everybody to realize, and surgery isn't about getting the stomach full, making a patient, get full, have vomiting. It's about changing things that go on inside the body that aren't working well. This is one example of many, but hopefully you get the idea that we're treating a disease, okay? It's odd to say we're treating it with surgery, but there are physiologic changes that occur to surgery, and we're finally figuring this out. And like I said earlier, I think eventually we'll hopefully be able to mimic this pharmacologically and not do surgery. I think one of the main focuses we're here to talk about is surgery, so I'm going to spend a bit of time on that. Here at the Weight Loss Center, we're a comprehensive deal, and we cover essentially every type of surgery that you can treat for obesity. The most common being the three listed here, which is the sleeve gastrectomy, the Roux-en-Y gastric bypass, or the bypass or the gastric procedure, and modified duodenal switch or the duodenal switch procedure. Many of these have several names. They're all done with laparoscopy. In other words, they're all done with the small incisions. They're all done with general anesthetic. Each of them requires an overnight hospital stay. So if you had surgery on a Monday, you're most likely to go home on a Tuesday afternoon. It's about a 1 to 2 week recovery after surgery. First week, not so pleasant. Second week, not so pleasant in terms of incisional pain, moving around a little gingerly at home, getting nausea under control. But by the start of the second week, should be feeling better, in the third week, kind of back to normal. With these surgeries, you experience life the same, really. So it's not like one surgery you can eat a larger meal and still lose weight compared to the others. In my opinion, there's pluses and minuses to all of them. One surgery may be fit for one particular patient, and that particular surgery may be better, not so good for another patient. So we'll go ahead and get started and discuss the sleeve gastrectomy. Now, it's called sleeve because of, not because there's an external device around the stomach, but because the end product supposedly looks like the sleeve of a shirt, but really it looks more like a banana-shaped stomach. So again, with the patient under general anesthetic, with the laparoscopy or small incisions, we use a stapler device and we remove about 80–85% of the stomach, which hopefully you can see in your screen at home. It's a lighter colored part of the stomach, or the part on the PowerPoint that's to the right, that ends up coming out, excuse me. So after surgery, your anatomy is all the same from mouth to rear end. You just have a much smaller stomach. And you can imagine before surgery, it takes, really a stomach can expand up to 40 ounces or so. It takes a decent amount of fluid and food matter to get in the stomach to stretch the stomach. Once the stomach starts stretching, little nerve fibers on the stomach send a signal to your brain. You have this feeling of fullness. Well, you can imagine with this picture here, if a patient has a much smaller stomach, just a little bit of food will get in there. That stomach will stretch. Little nerve fibers on there will send a signal up to your brain. You have this feeling of fullness. Every patient we have come to the office, they meet with our wonderful dietitians that are geared towards just caring for our patients. I did mention that earlier, but really from the initial consult up to surgery, most of the time spent with the dietitians getting ready for surgery, talking about what we want you to eat, when we want you to eat, what we want you to do while you're eating, what we don't want you to do while you're eating, so that when surgery date rolls around, we're all on the same page and we can move forward. In those meetings, you'll see small or food models that'll be small, of course, and you'll be like, there's no way that's going to make me full. But you'll have to speak to somebody who's been through it or trust us. You will get full on much less. And a lot of times patients are afraid their brain's going to want more. But really, what you take in will be enough to stay healthy, but small enough to get you to lose weight. And like I mentioned, this hormone thing changes and patients just aren't hungry and they move on to the next task. So in this picture, basically you can tell patients get full on much less. They take in less calories, they spend more calories, they lose weight. I would say the advantage is it's very safe, it's very effective. The disadvantages, comparatively speaking, as we talk about the sleeve, the bypass, and the duodenal switch, on average, patients can lose more weight with the next two surgeries, which we'll talk about. And one other side effect is this: about 5 to 10, maybe even higher, patients could develop heartburn after this. Sometimes it's mild, they take a medicine every once in a while, but sometimes patients do have trouble with it and have to take a medicine daily for that. We've kind of already had this discussion. Reducing the stomach size down does limit the amount of food that you can take in, but it really has an impact on that abnormal hunger hormone. In other words, that spikes up in between a meal, but after surgery does go down like it's supposed to. You lose about 50 to 55% of your excess body weight. So we would, of course, that's not your total weight. We would, of course, calculate this in the office, but basically you have a patient's ideal body weight, you have what their real weight is, and then whatever a patient weighs over that, that's their excess weight. So if you're 100 pounds overweight, you lose 50 pounds. 200 pounds, you lose 110 and on. We kind of talked about advantages, disadvantages. Another advantage is all the food that you've eaten is absorbed. So we haven't adjusted any anatomy. So you really shouldn't have any vitamin or mineral deficiency with this. Comparatively speaking, a little bit more weight loss with the next two surgeries. There is some, we're always worried about some patients that regain weight after surgery. There's usually a host of reasons, maybe a stress, a job change, a move, a divorce. They may turn back to food to cope with those things, which is totally understandable. Luckily, we have the dietitians and the bariatric doctor to help us. But comparatively speaking, that may occur a little more frequently in the sleeve than the bypass or the duodenal switch procedure. The next procedure we do quite commonly is the Roux-en-Y gastric bypass. Anatomy shown here in this picture. It's been around since 1955. Was surgery originally done for gastric cancers, which were more common back then, or ulcer surgery, and a couple surgeons like, hey, these people that we do this on are losing weight, and they started looking into it as a weight loss surgery, and it really hasn't been changed much since then. Instead of, as you can see here, instead of removing a good portion of the stomach, we take a stapler and we create a new stomach pouch, which is listed up there as stomach pouch. So you can imagine, just like with the sleeve, that this patient will get full on much less. But in addition to that, we reconnect the intestines up there, and we do it in a way that less food gets absorbed. So with this surgery, you take in less calories, and then of the calories you just took in, less gets absorbed. So you could lose up to 20–25% more with this surgery compared to the sleeve gastrectomy. So I would say the advantage of this is very safe, very effective. Unlike the sleeve where part of the anatomy is removed, this could be reversed, but really don't ever have to do that. One thing I did mention, as we move through sleeve, bypass, and duodenal switch, the weight loss does improve on average. But another thing that happens is with these second and third surgeries, the diabetes that patients get really starts to reverse quicker as we move through surgery 1, 2, and 3. In fact, 85% of patients that are diabetic or overweight. So there's a clear association. If a patient is to lose weight, no matter the way with which they lose weight, their diabetes will improve or quite possibly resolve. With oddly enough, and this is where a big center of research is, that patients that have bariatric surgery, they come into the hospital and they have bariatric surgery, they leave the next day, they haven't lost weight in a day, but their diabetes starts to go away. In fact, they just go on a different set of medicine. So with these surgeries, especially the bypass and the duodenal switch, something flips switch inside the patient that we're trying to figure out exactly what that makes them more, the insulin work better and the diabetes get better. In fact, they've done this surgery on patients that have type 2 diabetes, their normal weight. They do this surgery. They don't want the patient to lose weight. The patient doesn't lose weight, but their diabetes goes away. So we've got to figure out exactly what's happening with this to, treat as many people we can with diabetes. But these surgeries are excellent choices for diabetes. In fact, the American Diabetes Association and the International Diabetes Federation advocates for surgery. And those are medicine doctors advocating for surgery. So back to the surgery, I would say very safe, very effective. You could lose about 25% more weight loss than the bypass. You don't get heartburn with this surgery. In fact, it's a great surgery to treat heartburn. One of the downsides is you could get a vitamin or a mineral deficiency with this. We do have patients take a bariatric specific multivitamin and a calcium. So truth be told, if patients are taking that, we just don't see it very frequently. In fact, we only check vitamin levels twice a year, the first year and once a year thereafter. So the point is, it's just not a common issue. And if it is, it's usually they're just low in vitamin D or low in vitamin B, and we say, hey, take some more until your next visit. So again, how does it work? You have a smaller stomach, no doubt. Operating, which makes you feel full sooner, operating on the stomach does reduce those abnormal hormones. There's another set of hormones that change that help with diabetes that we're not mentioning here that do get better with the operating on the small intestine. So we think that's why the bypass and the duodenal switch help quite a bit. So in that 100-pound scenario, instead of losing 55 pounds, you'd probably lose 70, 75 pounds. 200-pound scenario, you'd lose 150 and so on. So you lose about 70, 75% of your excess weight. I would say this is the way I look at it, greater weight loss than the sleeve, quicker diabetes reversal than the sleeve, maybe a little bit less than the duodenal switch, which is what we'll talk about. Another disadvantage is that vitamin deficiency, which in my opinion is not that significant. One issue with this surgery is if a patient were to smoke, if they were to use anti-inflammatory medications, they can have trouble with inflammation of the stomach or even development of ulcers, such that if the patient does choose this surgery, we want to make sure we get those things stopped or discontinued so we don't run into that issue. That tends to occur less so than with the sleeve or the bypass. Then there's a third surgery we commonly do. It's called the modified duodenal switch. The modified comes in because this surgery was done decades ago over in Europe and in the US, and it's been modified in the early 2000s to make it even safer than it was before. So it's a change from its original surgery. That's why we use the word modified, but probably not that important for the purpose of this discussion. But we do call it the duodenal switch or the DS, and not a lot of centers around do it. You do have to be technically good at doing the surgery. You have to, watch the patient's vitamins afterward. You have to have the support with the dietitians and the office staff, which we have. So we're lucky enough to have that and be able to offer this to our patients and maximize the benefits of surgery with this procedure. As you may have figured out and hopefully see in this picture, it does combine the two surgeries. So we do the sleeve shaped stomach. So we do remove a good portion of the stomach, just like with the sleeve. And then we do the bypass part, just like with the second surgery. So you have the sleeve component and the bypass component. By bypass, I mean we're creating a scenario where less of the calories get absorbed by the bowel. So in this particular surgery, we do that, but we do end up bypassing a little bit more intestines, okay? So with this surgery, you do have the maximum amount of weight loss. So I would say with the sleeve, you lose about 55% of your excess weight. With the bypass, around 70, 75 maybe, and this more like 80, 85%. So none of these surgeries do you lose all your excess weight. And most patients are not interested in that. And it's fascinating to me that when we talk to patients before surgery, they do have a place that they in their mind that they want to be, and somehow the brain gets them there, the surgery gets them there. They end up oddly enough hitting that goal and not going too low, or hopefully not there. But with this surgery, we do bypass more of the intestines, so you can lose the most weight loss. Because of that, we do check labs additional time in the first year, and instead of taking 2 multivitamins, we have a patient take 3 instead. So yes, there's a chance that you could have a deficiency with this, but because we know it, we prevent it, and it's really not that much of an issue. There has been some concern with that patients may have diarrhea with this surgery because we have bypassed things, but truth be told, we just don't see it. In fact, most people can worry about food passing through too much or having diarrhea, but really, if there's any bowel habit change, it's we see it as constipation. Because one example you learn is we don't want patients drinking water while they eat, because when they drink that column of water may push food through the stomach, and they have they may be able to eat too much before they get full. So patients do a great job of that because they want to get full, but they don't do such a good job of drinking liquids. So constipation can be more of an issue. But again, I'm not trying to make this sound super rosy or too light of a subject, but really the benefits are exceedingly high, and the risks are relatively low when you look at surgery in and of itself. So you'll have to talk to somebody hopefully the best person to find this out about is friends and family or coworkers that have been through it. See what is good for them, what's been bad before you make a decision on surgery. We kind of talked about this and saw in the picture, we do make a sleeve-shaped stomach, and we do end up bypass more intestines, so you can lose the most weight loss with this. And again, these are averages, so there are scenarios where patients with the bypass lose more than the duodenal switch, or the patients with the first surgery, the sleeve, lose more than the bypass. And again, when a patient comes into the clinic, we kind of go over all these issues. We go over the patient's health history, their medicines, their ideas of surgery, and for the most part, they've made up their mind based on positive experiences they've had through other people. And we don't really get in the way because they're all great choices. But if there are certain scenarios where we at the center say, hey, we think this is a better idea, we'll strongly recommend the patient. But it's ultimately up to them to choose. So advantage of this, we've kind of already hammered it home: most weight loss, most effective diabetes, least likely to gain some of that weight back with this surgery. And should you need to take ibuprofen to leave, that kind of thing, it's not as impactful. What else? I could spend all kinds of time talking about the benefits of surgery, and I don't. This is just one simple study out of Case Western, and it's years ago. And I get a journal every month that is filled with other studies that show the benefits of surgery. So I discussed diabetes, high blood pressure, high cholesterol. Those are big problems for patients. Lead to a lot of medications, a lot of health issues. And we tell patients, if you have high blood pressure or high cholesterol, you can expect at least 60% of the time that your blood pressure will be normal, your cholesterol will be normal, and you'll be on no medicine. And that's to me very impactful. That's a big deal. Even a bigger deal is the diabetes. You have that number even higher. We say about 85% of patients can have diabetes go away altogether. So you could go to an endocrinologist or a primary care physician. They could manage your diabetes. Your blood sugar would be perfect, but you'd be on medicine. With this surgery, your blood pressure will go normal, and you can be off medicine. If you just consider a patient improved, it didn't resolve and improve, all those numbers jump up to high 70s, low 80s in all those diseases. So clearly, this has been repeated in many different studies or many different centers over many different time periods and many different geographic locations. So this is stuff that works. I know I'm the guy selling the snake oil up here, but you have to trust me, it works. If not, speak to somebody who's been through this before. And to me, it's the most satisfying part of the surgery, but really what patients want, we're all fired up about the medicine go down, but really what patients talk about is, hey doc, I can go to Worlds of Fun now. I can park my car far away and walk. I can now get in a single airplane seat. So they're excited about that. And the common thing we hear is, doc, I wish I would have done this years ago. So if you're at all thinking about it, I encourage you to speak to somebody that's been through it. The likelihood they'll tell you should get to it sooner than later. It's not perfect. There are things that can go wrong, like I mentioned. Luckily, they're down on the low side. So the big thing about operating on human anatomy, if you put a stapler on there or stitches on there or glue on there, whatever the particular procedure is, there are things that go wrong. And the main thing is bleeding from those particular areas or fluid leaking out or infection. So staple line leak is basically fluid leaking from a staple that looked perfect during surgery, but something may have happened after surgery. Patient complains of, fever, pain, something doesn't seem right. They would come back to the office or the hospital, and we would make the obvious diagnosis and get it treated. Usually if you get a problem addressed sooner than later, a small problem doesn't become a big problem. Bleeding happens about 1% of the time. Excuse me, it's not like on the movies where you have to go rushing back to surgery. It's like, hey, this patient's blood count was a little bit low. Let's stop the blood thinner that we have them on for blood clots, maybe watch them another day in the hospital. Very uncommon that you need repeat surgery for those. Stricture, that means where we did the surgery, there's a little bit of scar tissue buildup that happens infrequently. That doesn't necessarily need surgery to get fixed. And I kind of already mentioned the heartburn with the sleeve. I don't know if I'm making too big of a deal of it, but heartburn I think gets overlooked as a minor complaint, but people that suffer from it, it's quite a bit. We hate using the word mortality in surgery, but I think it's important. Ignore all this gibber down here. This is a study out of the VA. The two line graphs are really the message I'm trying to deliver. So the VA Medical Center, many other medical centers have looked at the mortality of surgery compared to not surgery. Well, VA is not the healthiest group of patients, so they probably are lean towards the higher end of complications in surgery. But despite that, it makes total sense to do surgery. So if you look on this, years after surgery, 0 to 12, and then you look the vertical axis, what % of people end up passing away? Well, you can see over time, you have a 10 times more chance of dying from the diseases of obesity than you do heading to surgery. That's a big deal. So there are two main reasons patients don't pursue surgery is they're afraid and they feel like they failed. Well, the feeling like they failed part is a message that we've got to, as healthcare providers and just caring lay people to pass on to other people is this is a disease. Yes, people do negatively impact the disease by way of lifestyle, but patients that are overweight frequently don't eat too poorly and they don't eat too terribly much. They just have a harder time staying full, and then they do too good of a job at storing fat calories. So we just need to, we have to pep up patients in the office. Like, look, you have a disease. You need to quit hammering yourself about it. You've been doing things that aren't going to help. You could do it 10 times over and it still wouldn't help. You need to get to the disease process treatment, which happens to be surgery, oddly enough. The other reason, I guess, of course, is they're afraid. And then we tell them, look, you're much more likely to die of your disease process than you are your surgery. So again, this is a study or outcome that's been easily repeatable over time. I think it just sounds odd that surgery is a treatment for obesity. But one last thing is, the there are a lot of factors that go along with obesity. I didn't talk too much about environment, but we're living in a setup where we're living in a scenario where people that are set up for obesity now are really in a bad scenario. So like if you had a patient that's predisposed to obesity that lived decades ago, and then you moved them into this, century or whatever, we now have third shift jobs. We now have computerized jobs. We have busy schedules. That tends to reduce activity, and the environment works against them. We have the fast food industry, which, luckily is very cheap, very convenient, but unfortunately dense with calories and not so helpful. So you can move somebody years ago that was normal weight, probably move them into this environment would be a different case. There are behavioral issues associated with obesity. So if we did surgery, didn't address them, probably going to have less than good outcomes. So what do we do about that? We have a psychologist in our office that's just working for our patients, getting them, trying to identify problems before surgery. For example, not really problems. Patients often have anxiety or depression. They turn to food, understandably, to deal with it. Well, those things are not going to go away after surgery. So what are we going to do about it? We found out if we start having those discussions before surgery, when those issues reappear, they become less harmful. So I think the point I'm trying to make is we've got to cover all the aspects of obesity. And I keep saying it is a disease, but there's no doubt it is. And there's a bunch of factors that are involved with it. Yes, I do surgery. Yes, it is the definitive treatment for it, but we owe it to our patients to cover all those things, which I'm excited about our program, which, as you can see, is the total weight loss program, because it's not the surgery weight loss program. It's, hey, the patients came through the door. Most of them are at their wits' end. They're looking for help, and we individualize it. Say, hey, this is, yeah, we offer surgery, but we also offer these things, and we're committed to you to make sure we get you the treatment you deserve, and we're not going anywhere. In fact, we expect you to come back to our office 6 times in the first year and at least once a year thereafter. We expect you to join our support groups for yourself and for our other patients that need your help. So it's really, to me, been quite a journey in terms of helping patients with this difficult problem, not only with surgery, but seeing the dietitians helping, the psychologists helping, the support group interactions, and people just coming into clinic much healthier and happier. I think I'm proud of what we built. The other nice thing that we have is a whole hospital connected to us. So I mentioned there are things that can go wrong with surgery, but there's cardiology, radiology, ER, pulmonary, medicine doctors, surgery doctors, all walking around here every minute of the day. So if we do identify a problem, we can take care of it. It won't be such a big deal, so that the, again, the patient gets what they deserve. But I just want you to know we'd love to have you. We're excited about the different things we offer, and we just enjoy it quite a bit, and trying to get as many people to surgery as we can, because that is how you treat this problem.
Well, thank you very much, Dr. Berghoff. That was fascinating. We have a few minutes for questions. I do have one personally. At North Kansas City Hospital, we have a very robust group of orthopedic surgeons who do joint replacements. And in fact, North Kansas City does more joint replacements as a single hospital than any hospital in town. What happens if I am obese and need some weight reduction, but also have a bad hip or a bad knee? How do you approach that? What comes first, the joint replacement or the weight loss? What should we do?
Undoubtedly, weight loss beforehand. And interestingly, there was a study in American Bone and Joint Journal that looked at patients with a BMI over 40 before and after knee replacement. And because on average, the knee replacement costs $7,000 more per joint because of the complications that are related to it. And that's mostly centered around wound infections. But for every pound of every pound that a patient loses in weight, it takes 4 pounds of pressure off of a joint. So you can imagine you put a new knee in a patient that's significantly overweight. That's a lot of stress, even on a mechanical knee, and it may be that they need a second one down the road. So our orthopedic guys know this, of course, and we have a program set up that if a patient has a BMI over 40, we have them navigate through weight loss to try to get them below 40, and frequently they end up in our clinic having weight loss surgery, then proceeding to their hip or knee replacement.
One of the things that I found fascinating in your presentation was the positive effect in reversing diabetes, high cholesterol, high blood pressure, and sleep apnea. What happens to the obese patient that has heart disease? Do you send them to the cardiologist, for example, to make sure that their heart's strong enough to go through surgery?
Yeah, the top two are the people that send us the most patients is cardiology and orthopedics. Oddly, well, not oddly enough, but and the reason being is they recognize the association between the two, orthopedics and the mechanical problems of a joint. But cardiology probably is the group of patients that send patients most to us. So they're also, many of our patients are seeing a cardiologist, and they're on multiple medications for cholesterol, high blood pressure, and may or may not have had a prior heart attack. So that's all mostly driven by weight. So we frequently have them sent to us, so they're already under the care of a cardiologist. If there is a patient that has, high blood pressure, high cholesterol, and medications, and they haven't seen a cardiologist, then I frequently will have them be seen beforehand to say, hey, obviously I'm not a cardiologist. I have identified a potential risk. What do you guys think? Should we do any testing before surgery, or should we can we head to surgery? Another thing we have at our disposal here, which is great for specialists, is the hospitalists, which are, many of you guys may know, is a medicine doctor that works inside of a hospital. So many of our patients have a lot of medications, a lot of which I'm not accustomed to dealing with, and a lot of them are going to change before they go home. Not a lot of them, but maybe the diabetes one. But nonetheless, I have the ability to also not just patients with heart disease, but pulmonary disease and other things, say, hey, we have them see the hospitalist beforehand, just to let them know we're preparing to do surgery. Do you have any testing you'd like to do? And while they're here in the hospital just overnight, please see them with us, which of course they do. And then I can just focus on surgery, make sure nothing goes wrong, and they can help them decide what to do with their medicines after surgery. So yeah, we'll get them to either cardiology if they haven't been already, and possibly medicine doctor too.
Okay, so there's one other thing that we do very well here. We have a sleep center, and we take care of sleep problems. Our sleep specialists often prescribe the CPAP machines. What I would like to understand, I know that in your slide, you said that 80% of people with sleep apnea got better, but have you seen cases where you've done bariatric surgery and people have been able to get away from their sleep apnea machines, or CPAP?
Yeah, absolutely. So we have many patients, I don't want to say all, but boy, there's a lot of people that have obstructive sleep apnea. And if they don't, we have them fill out a questionnaire, and if they have identifiable risk factors, we will send them to, like you said, our pulmonologists, which have a sleep lab, and they do an excellent job to get them ready for surgery. Yeah, like that number of cases can get better with sleep apnea, and they often resolve. A lot of patients will describe, like, hey doc, my CPAP, or my mask that I use for sleep apnea, started fitting looser because I've lost weight. It would fall off, or in the middle of the night, throw it on the ground. I would wake up rested. My sleep apnea is gone. And I would say, well, technically you're supposed to go get retested and make sure it's really gone. Some people do that, but yeah, I have, that's not an uncommon report, is resolution of sleep apnea even after surgery. And to the patient, they love it because they, are more energetic, they feel better, more things, they're, get more out of life the next day. But in terms of cardiologists love it because it helps with their heart disease. Pulmonologists love it because it helps with pulmonary hypertension. So, and in this era of Alzheimer's and dementia, a lot of the memory storage issues occur at night. So untreated sleep apnea has a lot of health issues related to it. So we need to get that's as important as heart disease. But yeah, that's a common issue. We like to get them retested and make sure it's negative, but that happens.
Okay, here's a quick one. This is a question from the audience. When is the safest, quickest turnaround time a patient that has bariatric surgery can then have a total joint replacement?
Usually, we want them, that's individualized. One of the objective goals is to get the BMI below 40 because we do know that makes them a healthier candidate for joint replacement. We want a patient to get through the surgery and almost, at least through the first 3 months. There's a lot of the weight loss that occurs 0 to 3 months. In fact, in that scenario, if you were to lose 100 pounds, you lose about 50 pounds in 3 months, which seems a lot, and it is, but it's healthy and safe and done, thousands of times. You lose the next 50 in the next 9 months. So we want to get them through 3 to 6 months of weight loss, and then and if their BMI is below 40, then we start planning at that point. But it ends up being almost a year or so since their weight loss surgery. And then in terms of the year and the weight loss thing, it takes about a year to lose all the weight. It's like 12 to 18 months. And the majority of it's in the first 3 months, which is something I didn't mention.
Well, I only have one other comment. I've been driving around town. I see your billboards everywhere. I love the logo. I love the look. It's really a great representation of the work that you're doing. So as I wrap up, I want to thank all of you for joining us today. We hope you gained some new information about the health risks associated with obesity and the various surgical and non-surgical treatment options available at the Total Weight Loss Center. To register for our free weight loss surgery seminar or to get more information about medical weight loss, visit totalweightloss.com. That's totalweightloss.com. Thank you very much and have a great afternoon.